Thank you. Thank you, Dr. Lieberman and Dr. Forrest, for the invitation to be here. I have no disclosures. I know it's late in the afternoon, so maybe I can wake a few people up with some pictures from Antarctica that I took a year or so ago. I do think this is an important topic. As I was speaking with one of my colleagues earlier today, these folks don't have a long time to live, and every day does count. And I hope I can make the case that as thoracic surgeons, we should be involved in the care of these patients. This is the normal chest x-ray that you see from someone with a malignant pleural effusion. The incidence, about 50% of patients with a variety of malignancies will develop a malignant pleural effusion. About 150,000 a year in the U.S. The most common histologies in men, lung and lymphoma and leukemia, and in women, breast and GYN malignancies. The effusion results from an imbalance, obviously, from increased fluid production and extravasation and impaired lymphatic outflow. The life expectancy does vary significantly, a mean of about 211 days, but a significant range, and it does vary, obviously, by histology. There's been some attempts at stratification, looking at pleural LDH, ECOG status, some cytology and tumor type, and you can see there that they are able to stratify the prognostic score and life expectancy. That will become a little more important here in just a second. So before we treat, who should we treat? Because again, unlike some of the other diseases you've heard about this afternoon, we're not going to cure any of these people. We're simply trying to palliate them. So obviously we should treat symptomatic patients, effusions that do not respond to the treatment of the underlying malignancy. I'm not a fan of treating asymptomatic patients or patients near the end of life. The goals, again, are palliation. We provide no survival benefit. Considerations are relief of symptoms, quality of life, patient and family acceptance of the intervention, affordability, and avoidance of invasive procedures when possible. So just to run through the treatment options quickly, because most of us are very familiar with these. Thoracentesis is usually the first procedure that occurs. The optimal patient for this is an initial presentation, effusions that are slow to reaccumulate in patients who are not chronically anticoagulated, who have access locally to care, and poor performance status, short lifespan. Advantages: easily obtainable, relatively inexpensive, again, over the short term, low risk of complication, especially with image guidance. Disadvantages: often you cannot drain the entire effusion, provides temporary relief, and at times, operator-dependent results. The indwelling pleural catheter, or tunneled pleural catheter as it is known, has become very ubiquitous in this condition. Optimal patients are patients with rapidly reaccumulating effusions, patients who need to be maintained on anticoagulation for other reasons, poor performance status, and patients who don't live close to medical care. The advantages are that this can be maintained at home or in a facility such as a SNF, can remain in place for very long periods of time, and they do have a spontaneous pleurodesis rate of about 30 to 50%. Disadvantages: there is an ongoing cost for the drainage kits. They may require assistance either from family or caregivers, and there is a potential for infection of about 5%. And then VATS. The optimal patient is usually a patient who requires diagnosis, either of the primary malignancy or, if it's going to make a difference in their care, of what may be pleural metastasis. Also, patients who refuse the indwelling or tunneled pleural catheter. In my practice, I have found that patients with malignant ascites and a sympathetic effusion are often best treated with VATS, and patients who are good performance status. Advantages: it does allow for a tissue diagnosis, and there's no need for a long-term indwelling pleural catheter if a pleurodesis or other pleural procedure is performed. Disadvantages, obviously higher initial cost does require hospitalization, and there is a risk of morbidity. So besides a diagnosis, what are you going to do at the time of VATS? You're going to do a pleural procedure. And that can either be in the form of a pleurodesis with either a chemical sclerosant such as doxycycline, or what we've been starting to use more of since we can't get talc right now, betadine or talc. These are very effective. Betadine is about 85% effective. There is a significant recurrence risk, and I think it's highly effective in most patients. You can do a mechanical procedure, such as a pleurectomy. I personally don't do very many of those. I think it incurs a long hospital stay and the risk of significant morbidity, but it is very effective. Just for completeness, I'll mention a pleural peritoneal shunt. The shunt placed from the pleural space into the peritoneal cavity. It has a one-way valve that allows flow from the pleural space into the peritoneal cavity. It is not passive, it's active. Requires the patient to be involved, and for that reason, my personal experience is that they have not been very successful. I think a 10% failure rate is pretty low. In many programs, it has been replaced by the tunneled pleural catheter. I call this one husband and wife. You can decide who's who depending on your gender out there. Let's talk a little bit about comparative effectiveness for just a second. This is a study done by Dr. Putnam at MD Anderson comparing the tunneled pleural catheter with a doxycycline pleurodesis. This is probably the best study out there on this subject. They found a significantly reduced hospitalization, median of 1 day versus 6.5, with equal effectiveness between the two modalities. There were more complications related to the pleural catheter at that time than pleurodesis. What information does cost add? This is a very elegant study done by Washington University in 2012, where they compared the costs of patients living 3 months with these different modalities. And what they found is that bedside pleurodesis probably was the best value if you were not going to live very long and if your lung could fully expand. Tunneled pleural catheter was the best modality for the majority of patients. Thoracoscopic pleurodesis if diagnosis required, and interestingly, repeated thoracentesis over time was the most expensive, and those are patients who lived at least 3 months. Just a quick word about novel strategies. There has been some work looking at placing a tunneled pleural catheter and then performing a pleurodesis through it. There was a pilot study looking at this using talc. It was very effective, 92% effective. 92%, interestingly, of these pleurodeses were accomplished as outpatients, and a few morbidities. So that's something that is being studied further in larger groups of people, but may hold promise, especially if you place a tunneled pleural catheter in somebody and they go on to do extremely well and live a long time and don't spontaneously pleurodese. This is some work that we published a few years ago looking at a VATS for patients who required a diagnosis, and we propensity matched folks who had either a standard talc pleurodesis with a tunneled pleural catheter. So in other words, in the pleural catheter group, you went to the operating room, you did a VATS for diagnosis, and instead of doing a pleurodesis, you simply left a tunneled pleural catheter as your pleural drain at the end of the procedure. Generally place that to a Pleurovac for 24 hours, and then if there's no air leak, cap the catheter and send them home. We saw equal improvements in their symptom score, a much shorter length of stay in the pleural catheter group, and significantly fewer reinterventions needed compared with talc pleurodesis. Another potential paradigm is the tunneled pleural catheter, which is impregnated with a sclerosant. In this case, a tunneled pleural catheter impregnated with silver nitrate. There's a multi-center trial ongoing for this. Many of you may be involved with that. Our center is, and we'll see what that bears. And so this title is, this presentation is entitled Algorithm. So I thought we better talk about some algorithms. There are many out there. I think many of them, as a surgeon, are overcomplicated. This is a very reasonable algorithm, which takes a lot of consideration for pulmonology and thoracentesis. Another, I think, more simple algorithm from the Swedish group in Seattle. But I'd like to put forth this algorithm, which I think is simple and reflective of what's commonly available. So a symptomatic patient or an asymptomatic patient requiring diagnosis is generally going to undergo an image-guided thoracentesis with cytology. The exception may be a very symptomatic patient who is near the end of life, who simply needs a tube thoracostomy and a pleurodesis. If you're able to get a diagnosis from the thoracentesis and the patient does not recur, great. Initiate systemic therapy. If the patient does recur, we can stratify those patients by slow recurrence or rapid recurrence, and then by life expectancy as to the next step. In general, in my practice, we default to a tunneled pleural catheter unless it's a very slow recurrence and a short life expectancy. In patients who were not able to have a diagnosis achieved with cytology, or who have a very rapid recurrence and have a significant component of malignant ascites, we would then proceed with a VATS pleurodesis. Previously, our primary sclerosant was talc, but because that's very difficult to get now, we have been using betadine, which has worked very well for us. If you do perform a pleurodesis and you have a recurrence that's significant, we've been a fan of placing a tunneled pleural catheter at that point. So in summary, most pleural effusions can severely impair the quality of life of patients with malignancy. Systemic chemotherapy and or radiotherapy for the underlying malignancy may control the effusion in certain histologies, but 50% of those patients will require further treatment. Asymptomatic patients with malignant pleural effusions do not require treatment, and an initial step in all patients should be a thoracentesis with cytology. Repeat outpatient thoracenteses or an indwelling pleural catheter rather than pleurodesis for patients with a short life expectancy, especially if they slowly reaccumulate, are very good procedures. For patients with a good performance status who are symptomatic, who rapidly reaccumulate or perhaps refuse an indwelling pleural catheter, chemical pleurodesis, either via pleural catheter or thoracoscopy, is the procedure of choice, and take into consideration in those patients tumor histology, malignant ascites, patient preference, and the need for a tissue diagnosis. Thank you.